And then, hold on, let me see. Okay. All right, so welcome to the LGOST Think and Drink number 4. Okay, this is all going to be about special tests and just how special are they? And there's definitely a lot of debate with all the shoulder tests. Audrey, last week, she brought up a couple articles that I thought this would be a great topic to just go over. And I think just going over the validity of some of these special tests and really kind of reflect on our own clinical evaluation skills and seeing what can we do to change how we evaluate injuries, especially the shoulder. And I think another good injury too that we could also look back on is also the meniscus injury. But before we start our discussion, I know there's a couple new faces around here, so let's all just kind of introduce ourselves just one by one, and that way we can all get to know each other. So I'll start. So I'm Philip. I work at LGOST Orthopedic Sports Therapy as an athletic trainer, and I help out with Willow Glen High School. And I also run LGOST Strength, which is a strength and conditioning program out of LGOST Orthopedic Sports Therapy. Anyone else want to jump in?
I guess I'll go. I'm Paka. I know most of you guys. I'm at LGOST as well, an athletic trainer there, and working with the synchronizing team, Santa Clara Aquamates and San Jose High, and also kind of hired by San Jose State to work with the swim and dive team there.
Here, I'll go next. Scott Zimmerman, athletic trainer at Archbishop Midi High School. I think a lot of you guys will know me. Ross and I go back, I think many eons before you guys were all alive. So we go back a long way. But hello, and thanks for having me.
All right. So I'll back you up there, Scott, because I am older than you. So Ross Makaji, physical therapist, athletic trainer, worked with most of you guys at some level of capacity, things like that. Just kind of reading literature, trying to check out what Phil's doing, keeping our educational stuff going during the pandemic. So it's always a good thing to kind of share and learn. So it's a good way to do it, using Zoom, having a drink, and hanging out. So good to see everybody.
Hanging out on the beach.
Yeah.
We need to swap backgrounds, Ross.
No, I like this, man. It kind of puts me in a happy place. All right, go for it, Aaron.
What's up, guys? My name is Aaron. I guess I currently work for a private company called Offset Med. We mostly work with performing artists. I know Phil back when we were undergrad together, so been following his journey as well, and excited to meet you guys here.
Paul, next, or
yeah, you go, Justin.
Justin.
Hey, Ross. I'm Justin. I've met pretty much all of you guys. Athletic trainer for Los Gatos High School, and yeah, about it.
I'm Audrey, just graduated from CBU this past spring. BOC is next Saturday, so here we go. Yep, this topic was cool to me. I was joking around with people, like I didn't think that stuff we learned in school would be proved obsolete so quickly, type of thing, but yeah, that's it.
Yeah. All right, cheers, everyone. Everyone got something to drink. Cheers.
I'll go get my drink. I'll be right back.
Oh, all right.
Ross has to make his way to the sandbar.
Yeah. Okay, so I'm gonna refer to the frequency of use of clinical shoulder examination tests by experienced shoulder surgeons. So here, let me get that article up real quick. Okay, so it will be this article right here. Yeah, so this article by, I don't even know how to pronounce that last name, but it sounds really cool. By Aaron, Tracy, Ben, and Tim. Okay, so these the authors of this article, I thought this article was really eye-opening because they surveyed a lot of different surgeons from a lot of different subspecialties across the orthopedic field, and they surveyed them and asked them what special tests do they use. And across all the surgeons that they surveyed, there were only two special tests that were 100% across the board that they use, and it was the apprehension test and the cross-body adduction test. Just those two, and then everything else is just kind of sprinkled in between, just depending on, I guess, what they find with their patient cases and things like that. And I just find that really alarming. I thought that a lot of the shoulder surgeons would really, they would really have a lot more tools used or a lot more different tests before they get into the imaging and things like that, just to hone in on their differential diagnosis. But I was really surprised by that survey response. Just out of all the tests that exists in the medical world, across all the surgeons that they surveyed, only two of them are used across the board. I don't know if you guys have read the article, but if you guys have any thoughts about that, you guys can go ahead and chime in.
Hang on, I'm gonna open up that article on my screen there, Phil, because first I'll just kind of throw this out there. So this is the Journal Athletic Trainer one.
Yes. Yep.
Yeah. So I think that's kind of interesting because Kibler, Dr. Kibler is the guy who's really been known for scapular stability, like the naming of the three types of scapular winging. So superior migration, medial winging, inferior wing, things like that. So he's really involved in all kinds of scapular type assessments and things like that. So I think he may have even coined the scapular slide test or things. But I think, kind of going back to your point, I think they're really, what I've learned over time is orthopedic surgeons are extremely dependent on imaging, and as well as kind of the patient interview more so than actual special testing. And it's just kind of, they make that leap right off the bat. So what determines whether they're going to make a prognosis or things like that is what they see on MR, which is kind of bizarre, but I think it's partly due to our healthcare system where they just don't have a lot of time. But that's kind of what I was kind of gathering out of this article, was I think it's because they have so much better imaging now, that they rely on it much more than a physical exam. So Scott, I don't know, what do you think too?
Yeah, I was thinking about that. I think they do tend to rely on imaging a little bit more. I mean, our doc Glass will always, you need an MRI, you need an X-ray, you need something to go forward with that. I'd be curious, like, only these two tests were the most common, but I'm sure they all use a variety of their tests. They all have their screening process that they go through to rule out too. So I think, it doesn't show the whole picture that just the two tests were there.
Right. Yeah, and it just makes me wonder, like, how much, like, for a shoulder examination, how much do the special tests, or how much are the special tests valued for a shoulder examination? Because we can always talk about, like, the range of motion and things like that. I felt like, ever since I got out of school, I've always felt like the more shoulder cases that I've seen, the less I'm relying more on the special tests themselves, but more on, like, the range of motion and the actual like mechanism of injury. Like, I'm not, like, I guess from the apprehension test, that's probably like one of the tests that I'll use to, like, rule out a couple things. But other than that, I'm really just relying on what the patient tells me and what I'm feeling. But as far as like, let's say like a labral test, like the jerk test or O'Brien's, or even like any of the impingement tests, it seems like it doesn't really tell me much other than, okay, if I put this shoulder in this position, it's gonna hurt. And it seems like even if you do it on a healthy patient, it would still hurt anyway.
Well, the big part of it too is using your special test to kind of rule in and rule out what you consider what it might be too, right? Okay, well, I'm thinking it may be impingement. Do I want to go to that near impingement test, which I know is going to flare him up, or do I want to go someplace else first to see, is he impinged because he's loose? So how you put it all together gives you that indication. I would assume an orthopedic doctor would be that way and say, hey, let's rule and rule out. Yep, that shows me that there's that possibility you need to get an MRI.
Right. Yeah. It's just kind of like from the evaluation itself, especially with impingement cases. Yeah, I agree. It's like, do we still want to flare them up again and just? But we already pretty much honed in onto that diagnosis.
So I think, Phil, to kind of back up what you're saying, I think you're utilizing your subjective interview to really get a lot of information, whether it's a macro or micro trauma. Also, being on the sidelines, you could see some of that stuff, right? So you could see if they landed kind of funny or how they got up, how they're holding the posture of their arm, things like that. I think when you get into the special testing, if it's an acute injury, everything might hurt, right? Or if they do have a high inflammatory component, everything's going to hurt. If we go back to kind of looking at, George Davies and his whole thing of his shoulder testing algorithm, the thought process behind it is always using the rule of threes for passive tests, right? So most of these tests are going to be passive, okay? So the first time you test it, you're trying to get a general idea for what might be the problem, like the symptomatic tissue. The second is to really kind of implicate the structure that's at fault, right? The pain generator. And then the third is you corroborate findings. So I think, then he goes to the resisted tests where, if one time he only tests it one time because it might be provocative, right?
Mm-hmm.
So when you start thinking about that, what he's trying to do is cluster signs and symptoms. So then once he does something and does a specific test, he may either be able to do more tests or less tests that will back up what his initial kind of what he was thinking, right? To figure out that general idea. So that goes back to that whole concept of the hypothesis. So your hypothesis is initially based on what you got from the interview, then you're doing your testing and you're testing your hypothesis to find out what the implicated structure is. I think as you do this longer, you definitely start to figure out, I can cluster this test with this test and this test. And then, so all of them standalone may have horrible reliability, validity, inter-test reliability, things like that. But when you start clustering 5 or 6 tests together, they all start to become pointing more, like if they're labral tests, you do the crank or things like that, or you do the, what's the one, the pronated and then supinated crossbody, all those different ones. You could start to kind of see, hey, it's starting to implicate more labrum, right? Or the stability test. So you might do a load and shift, and then they do have a positive rim loading or a shear, a clunk or something like that. And then you put them in the apprehension, they get the apprehension sign, then you do the relocation, feels better. So that was 3 tests that you might have done because you were already kind of going down that road. You know what I mean? So I think that was one of those things that of the clustering of the signs and symptoms may allow people, especially that are practicing for a while, to minimize the number of tests that they may utilize. So
yeah, I agree. And I think just like the George Davies philosophy too, of just collecting enough data and creating that hypothesis and then confirming with the special test. I think that's just it's a nice process to get through, and just being able to stick with it rather than just kind of do guesswork and seeing like, oh, these structures may be implicated, but I don't know. Yeah, I'm just going to throw in a bunch of special tests and things like that. I also found from this article, what was interesting was in the biceps injury section. I'm going to scroll down. I thought this was pretty funny because they had the speeds and Jurgensen test, and they were saying how the speed test was originally used for diagnosing tenosynovitis, whereas the Jurgensen test was used for diagnosing the long head of the biceps subluxation. But when they were assessing the validity of it, there wasn't really much of an association for their own purpose of the test, and they would just diagnose them as some sort of biceps tendinopathy. So I thought that was pretty interesting. I mean, I don't know if anyone's ever diagnosed like a long head biceps tendon subluxation just off of that Jurgensen's, but I find that pretty interesting just reading that section alone.
Yeah, I agree with you, Phil, and a lot of the stuff that's been like discussed so far. I think it's really interesting to read an article written by an orthopedic surgeon because, you know, by nature, orthopedics itself is a very, I guess, like reductionist point of view in terms of like diagnosis is concerned. It's very like structural oriented because, you know, they're the surgeons are the one that are operating on the anatomical structures. So they look to that as like a source generator for pain versus, you know, PTs, ATs, like we have to see them day in and day out. So, you know, function usually will take higher precedence. And in terms of like, I guess, using these shoulder special tests, it's definitely evolved over the years, you know, like, you know, my thought process kind of went with like Ross's in terms of like, how do I best cluster these tests to create a more effective and efficient narrative that meets what the patient thinks is going on and what I think is going on internally. And then it wasn't until like, you know, I went to grad school and did an actual like cadaver lab, and, you know, you go in there and in the anatomy books, it shows everything so clearly defined, and you get into the body and it's just a capsule and everything's integrated, and then there's so many layers, and the instructor's telling you, all right, I need you to isolate the long head, the biceps now. Can you cut that out for me? I'm just like, I don't know. Can't really do that, but who knows? Maybe. I didn't go to medical school, but I doubt they have that amazing skill set as well. Like in terms of like how it translates clinically, it's, you know, like you said, it is mostly passive. And when I hear that, I'm like, okay, passive meaning that, you know, the muscles are, or the movement itself has to operate under less tension, and the tension being gravity, right? So what is it saying with, you know, in this context of gravity being gone, what is the person presenting with? And then if they're able to stabilize appropriately with their, you know, scapular stabilizers, rotated cuff, whatever, does that symptomology like change and alter? And does it get worse? Does it get better? And I kind of use that to kind of inform the rest of the evaluation practice.
Right on, right on. I mean, Audrey, what do you think? I think in the beginning when you mentioned like now that you're finishing up grad school and all of a sudden everything you learned is now going obsolete, like what's your thoughts on that, especially with the shoulder test that we're talking about?
Yeah, I'm kind of relating the content from this article to the other one, which was the Viewpoint, the JOSPT Viewpoint article.
Mm-hmm.
And it mentioned stuff like, you know, is this like taking from the education standpoint, like how are you most effectively educating future healthcare professional students?
Here, let me see if I can pull that up real quick. But yeah, Audrey, keep talking.
Okay. Getting back on my train of thought. Oh yeah, so like it's, I don't know, like just coming out of grad school right now, there wasn't as heavy of an emphasis on like putting that whole picture together for each patient. Like Aaron was mentioning a narrative, and Ross was also saying that like there is some, and you know, I think like at the time our minds weren't ready to comprehend what that meant. But now like seeing
a bunch of different clinicians, how they operate and how they take a history. And especially in this telehealth type of age where we can't really lay hands on people, how are we still able to treat? You know, we're just not really learning all those other clinical skills. We're just, you know, really focusing on the black and white nature of a lot of these special tests. So all of that to say, I just think that a more whole picture viewpoint would be better earlier on in education.
Yeah, I definitely agree with that.
I second that. I'm definitely sure still that Dr. Han at San Jose State still uses the same template that he used like 40 years ago about special tests that I know, Justin, you probably remember too, but
Yeah, nothing much changed on Dr. Han's curriculum.
no, nothing's changed. And it took me a hot second after I graduated and actually started doing special tests on athletes to like being able to cluster all those tests together. I was like, oh, this makes sense. Like, I wish we learned that in school. And also, I think it mainly comes down to clinical reasoning, as we kind of like talked with the other journal club, that like what special tests you use or what clusters you pick to use and go from those and do your eval according to those.
Well, let me see. There was also in the article that Audrey, you brought up. This is actually the first article that you showed me before I all of a sudden was like, oh, let's add 2 more articles and add on to this session. But there was something at the end. Let me see if I can find it. Like this part that you highlighted, continuing to rely on special test results and imaging to inform recommendations for invasive procedures such as injections or surgery in non-traumatic presentations is arguably not acceptable practice. So I felt like that statement just kind of like threw down the hammer. It was just like, it's just we really have to revisit how we evaluate our patients, and we just can't rely on these quick and easy confirmation tests and just all of a sudden like that doesn't give us the whole solution to our patient's problem, right? Because especially now, it's like a lot of these injuries that we're seeing, I feel like we're now seeing there's a non-operative approach to things. We're not always having to cut open someone and expecting them that the surgery is the next solution. And I think this also doesn't apply to just the shoulder. It's like it's to the knee, it's to the hip. I think there's definitely, it's good that we have all these studies that are proving that we don't always necessarily have to rely on the surgery. But do you feel like now it's like the imaging aspect of the evaluation, does it always implicate surgery? Like, do you feel like that trend is still going on in our healthcare field?
I don't think so. I think a lot of the really top orthopedic surgeons, they know that, you know, you can have a really bad looking MR and still function perfectly fine. You know, and it comes down to whether they believe that that's something that someone can rehab versus they need to do some sort of a surgical technique to stabilize it or something like that. Yeah, I don't know. I think it's still, you know, I think the MR is more of a confirmation to them. They'll go through a really quick thought process, do a very, very cursory exam, and then kind of default to the image. I think that's probably the biggest thing. I think what you're going to get, you guys have probably seen even with the fellows at San Jose State. So Justin and Paca, you're both are San Jose State folks, right? And I'm going to guess also Scott over at MIDI is, you know, some of those docs like really rely on this ultrasound thing now, right?
Yeah.
That's the new sexy thing, you know, to image, and they spend more time just trying to figure out the image than they could if they just did a physical exam, right? Or writing up the script to send them for an MR. You know, they're just spending so much time on it, and it's more that they're just finding that it's so cool to see. So how relevant that is, I would love to see some of the, you know, the literature that's coming out on ultrasound imaging for musculoskeletal conditions, because I know Dr. Blatz is a firm believer in it. I know the O'Connor Sports Medicine Fellowship, which takes care of San Jose State athletes, I mean, they just carry that thing around like it's, you know, the best thing since sliced bread. And I do think it's helpful, but I just don't think it's the end all be all.
Yeah, they spent. I actually had my elbow checked out by them, and they spent a lot of time just on that ultrasound thing. And it looks like a really medieval computer reside
Medieval.
little box. Yeah, like a little box, but it looks so old. But no, they spent like more time doing that than the actual test. And I mean, I kind of knew what was going in. And anyways, but it was, yeah, I could second Ross on that as well.
Yeah, wasn't
Yeah,
there? Oh,
go
sorry.
ahead, Phil.
Oh no, go ahead, Aaron. Go ahead.
I've definitely seen that trend a lot more, especially, you know, I work with a couple of PM&R physicians, and they're not doing the surgical basis anyway. So their caveat is getting really good with ultrasound diagnostics. And, you know, I feel like in an ecosystem where like the athlete or person is supported, like it makes sense to do that, because then you can use that data to inform like rehab or strength or whatever is going to come after. But, you know, if this is like the one ticket a person's got to go see a specialist, and they come out of saying that, yeah, they showed me an image of it and that was about it, it's not very helpful. And I think it's a lot harder, I feel like, convincing patients about it, because, you know, they go in and see an ortho specialist, they go and see a doctor who's like, they have a higher expectation in terms of like what they're going to receive from it, whether it's medication, surgery, or something else. But we know that, you know, in a lot of active populations that, you know, you take an MR of this shoulder, or, you know, someone who's been active for a pretty long time, they're going to see structural changes in the MRI anyways. And whether it's symptomatic or not, a majority of it is going to be asymptomatic. So like for a sports ortho, like it definitely helps if it's like acute, but I can't really see its place in long-term management unless it's, you know, part of a bigger network where you can like actually leverage that information in a better way.
Wait, so you're saying it's not the value of it is not really there in the long term, like if we're talking about like an injury that's just gone on for a while, or
Yeah, because I don't think it's gonna be as helpful to the person to like know that, unless they are the type to like want to have definitive answers,
right.
which some are. You know, I've definitely worked with a couple athletes and people that are just like, I just want to know. So they have the time and the income and the resources to go get an X-ray, to go get MRI, because, you know, I'm usually in a practice where we don't have those things in our vicinity, so they have to go out and seek it. But for the majority, it's like if they're able to make some lifestyle modifications and get on a good program, that seems to be something that they're more willing to do, and not be so much of as a burden than to go through the process of like making an appointment with a doctor, get disappointed with the doctor, or get offered surgery if it's not something they don't already want, and then go through that process.
Yeah, I see what you're saying. Justin, what are your thoughts?
It's out of my clinical experience. All for me, it was all for everything. It's subtle. Just knowing like range of motion. And I think the biggest one, piggyback like way back in the beginning, was like your questionnaire, like subjectives, and just understanding that. And then when I was like with the room with like with our Dr. Murray, he just noticed small little clicks within it, but full range of motion and everything else. And it goes back and he said, oh, get an MRI, and then that little subtle click was probably that, and then he would go treat it as a conservative route, and then PT. So that's about what I've been seeing on clinical side. So it's kind of like, if you think back, listening, everything is like how, like with the low back pain, and then you get an MRI on it, but there's no abnormalities with imaging, but there's still pain, versus vice versa. There's an abnormality, but there's no pain. The kind of same thing happens with the shoulder in my clinical experience.
Right. Well, I wonder, has there been any studies that have been out that compare the ultrasound and the MRI? I'm pretty sure there are, but has anyone read up on some of the studies about whether if one is more accurate than the other?
I don't know about that. I think, but if you really talk to some of these more experienced orthopedic surgeons, they're going to be pretty frank about it too. They'll say, even an MR image, which is the gold standard for imaging, they'll be like, it's still a digital image. So there might be something they miss, or it doesn't show the whole picture. So most of the older dudes, you'll hear that. I think the younger guys take a little bit more kind of into what they're seeing, and they'll, oh, it's got to be this, it's got to be that. But I think that's just based on pulling from a little bit of experience. But I don't know, we can look it up.
Yeah, that'd be interesting to see that comparison, and I don't know if the ultrasound is now becoming that latest technology that a lot of the orthos and the fellows are all hopping on, then I feel like, and plus now that even they're introducing the ultrasound as part of or they're including that in the athletic training education, at least for like the Con Ed part of it. I think it's something that we should all kind of familiarize and know exactly like how it works and what exactly we're seeing and things like that. But yeah.
I've talked to sorry, Phil, keep going.
Oh no, I'm done. Keep going.
I've talked to Dr. Hyde, Nicola, about it when I saw them a couple of times at San Jose State, and they said they really like the ultrasound because it's like a present thing. Like they see it as is when they have the actual head on the elbow or whatever it may be. And then the other reason why she said she really liked it, because if depending on what you check, you can actually like squeeze the muscle belly and stuff and see that movement and see like different angles of that whatever whatever like body part you're looking at. You can, like, they were, for example, to me, they were looking at my UCL at my elbow, and they were just squeezing my biceps and everything and kind of looking into the structures as is. And I guess it's just easier because it's right there and then, other than MRI, just to like get it done, wait for it, and then having to look at it later. So that was one of their reasoning, but yeah, I haven't seen any articles actually comparing the two yet.
Yeah, I would definitely say, that convenience factor is definitely a plus. I mean, if you can Amazon Prime everything at this point, it's like, man, our lives would be so much easier in the evaluation department, that's for sure. But
yeah, I don't know how it will be put in the education department of, AT or PT. I think you have to be very cautious about doing that. Because even talking with a physician, they're saying that they go through like full like residency trainings just to be able to interpret and read an ultrasound image. And I actually took like an imaging course from the PT department during my grad school too, and I thought it was pretty informative, but I still would not say I can read, these images. I can get a rough idea about where it's going on and what I'm supposed to see, but it's not my scope, it's not my field.
right.
And my fear is that like if it does end up in an athletic training clinic, and people are like are using it, then I mean, yes, there's like scenarios where like if you're going to be an orthopedic physician extender or a physician extender general, that just may be a skill and you'll actually get to use that practice pretty often. But for someone who's at like I don't know, that is like the only AT at a high school, and they part of their education was to learn how to read and interpret an ultrasound image. I think that time in the education series could be best utilized elsewhere.
Yeah, and that would just defeat the whole purpose of our session too. It's just like we're talking about why all these special tests and all these confirmation tests, like that's not the end all be all. We got to really evaluate the patient and know and understand what exactly was going on, and then we can utilize those special tests and the imaging and things like that. And I wholeheartedly agree with that, Aaron, for sure. Yeah, and I just think like now that we're on the topic of like that athletic training education part, it's like there's so many things now that athletic trainers are so exposed to, but at the end all be all, like, are we going to include that in our practice? I feel like it's just, it really doesn't make sense. Like, but I mean, I feel like that would be a whole nother topic for a think and drink session for a different one. But I definitely want to go over another injury that I feel like is really similar to what we're talking about with the shoulder test. I think the meniscus injury by itself, I think a lot of the special tests there, there's always some sort of validity concerns with that, especially like the meniscus test and all the different variations of the McMurrays and all that. And I still feel like at the end of the day, if there's still joint line tenderness and just based off of the symptoms that the patient is saying and what the mechanism of injury is, I would still just refer them to an ortho and get it checked out some way or form. But I think the article that I found, let me see if I can pull that up. So this one they were looking
like
at,
full text access to all these articles, Phil.
yeah, it's either researchgate.net or the NCBI. I mean, it's whatever is up there, or whatever Audrey sends me, because she still has CBU access. So.
Ooh, that's true. Yeah. I may have to send you to go get research article fetching.
That's my job.
You start a black market library service or something. Anyway, so we have so for this article, they were looking at the 2 weight-bearing meniscal tests and the 1 non-weight-bearing test, and just reading through the article, there was just very poor association against the gold standard of the MRI, and I think that's like then that's why I brought up this article for tonight's session, because it's like, well, with the meniscus test, like, are there other things that we can use to really hone in on that meniscus diagnosis? And I don't know what your guys' thoughts are on about that.
Philip, I think I would agree with you. I think I go more on joint line tenderness than I do on a lot of the tests, and then the patient history. What was the mechanism of their injury? Because yeah, McMurray's is difficult. Duck walk. All those are you don't always get positive responses. Or also it's like a huge tear and they can't bend their knee. Or else you have some big impairment. So I agree with you. I think going with the joint line tenderness is a big part of it.
Right. Yeah. I would agree with that. So I think one of the things you kind of got to look at is like, I can't remember where I saw this, but I think it was like 70-something, high 70% likelihood of having a meniscal tear with joint line pain. I think you're pretty safe with that. You can also get it with just end range flexion, with just kind of taking them in passively to end range flexion with rotation. And usually what will elicit pain is in the back of the knee. So I think that's something that I have found clinically to be as or more important is when people report posterior knee pain or a Baker cyst, what is driving the fluid that's causing that Baker cyst? It's usually a meniscal tear. So more often than not, if they have posterior knee pain with knee flexion or a squat or that kind of stuff, Thessaly, I think the thing that was a problem with this article, and I definitely remember this when it came out, was, and this is kind of talking about the primary care kind of level of doctors that don't, remember, I think this is another thing too, is primary care doctors don't have very much musculoskeletal training, period. The education in medical school is really, 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 really poor. So, they get a hold of a test like this that they can do in the clinic. And basically the Thessaly is just stand on one foot and rotate. And I don't know about you guys, but if you got someone with a meniscal tear, that sucks. And they will go down in your office, right? Or in your, on the field. So I don't think that's necessarily something that is an ideal test. And I think when you start looking at the deep squat, the Thessaly, those might be good tests that I would look at in a physical exam. Like when we're doing, middies physicals or Willow Glen's physicals, when we got guys busting through there and you're just trying to do a quick screen. But I don't think you want to do these tests on someone who comes in with knee pain, or especially an acute knee injury or knee pain, saying that kind of stuff that they're coming in there. So I think that's kind of where the Thessaly, you have to, and the deep squat, you have to look at your risk reward on what you're looking for. Because they may have just a joint effusion that's going to limit them to be able to deep squat, right? They may have like patellofemoral stuff or subluxing patella that doesn't allow them to rotate, right? You have an ACL, concomitant ACL problem with that, the Thessaly is going to buckle them, right? So I think you have to look at that risk reward. And I think that's kind of where you could start to see the specificity, sensitivity with these tests is, a lot of them aren't great, right? But I think you have to kind of look at when you're going to do it and why, you know what I mean?
Right. So there's a place for all these tests, but it's not exactly your go-to meniscal test when you're suspecting a meniscal tear. Yeah, so here's the thing too. So I was always curious about this, but where did all the variations of these McMurray's tests come from? Like, I don't know if you've seen, like, how many variations do you think there are of these McMurray's tests? And it bothers me because there's always, I remember in like the UCR clinical, so at UC Riverside, we had a preceptor and he would do this weird, like, put the two fingers on the joint line and he would literally, like, he would take that foot and just like crank it and do this. It looked like a magic trick. Like he would just like get the knee into full extension and all of a sudden he's just like twirling it around. And then when George Davies came by to teach the knee, it's like, oh, there's nothing fancy with it. You just go into some axial compression and then you just externally and internally rotate the foot, but you don't have to all of a sudden just like do this twirly thing that so many people do.
Yeah, I think that's a combination of a couple things with George. I mean, one, I think George is a little anal. Two, he's been doing this for longer than all of our lives combined, right? I mean, the dude's almost 80 years old and he acts like he's 21, right? So I think he took that, like, basically, Phil, to answer your question, was he literally read how Dr. McMurray did the test and follows that to a T. And so he went back and said, fuck all these variations, we're going to do it exactly this way because that's the way it was originally done in the literature. So that's kind of where he kind of came back with that. So I think sensitivity, specificity wise, I think it is, again, and it gets better with concomitant tests on top of that, So personally, in clinical experience, again, the thing that I kind of find is that posterior knee pain, more so than clicking or catching, as well as the joint line pain and an inability to weight bear with rotation too. So those are the things I always kind of think are the bigger things that you catch when you start talking to the patients and doing the exam as well.
Right.
Like those key takeaways, Ross.
Yeah, Philip, I would echo too how I was taught, my mentors, my professors. It was more of that egg beater type motion where you're really getting that leg moving and trying to force it. Our doc, Dr. Blatz, too, is like, no, all you're trying to do is pinch that meniscus. You don't have to force it through and go through all those motions. You keep it a simpler test. sounds like Dr. Davies is doing. Keep it simple and kind of look at what you're trying to accomplish with that.
Yeah, I just find it really weird. Like every preceptor has their own version, or yeah, even every preceptor and every professor has almost their own version of a McMurray's test. And I felt like that's just, man, it's frustrating. It almost could become like my pet peeve. It's just like looking at like what exactly is the McMurray's test, and just, yeah, I feel like it's just like a representation of like how we view some of these special tests. There's so many different kinds and little variations, but that kind of ruins our inter-rater reliability on some of these. And is that really best practice, right? If we have all these variations, like how are we not agreeing and being on the same page about it?
Mm-hmm.
Yeah, that actually reminded me of a story that I kind of just listened to recently, and it was about it was a post about Japanese, I guess like culture, and was it cultural appropriation or a compliment that they were able to pull off like African American and Black heritage, like hairdos, like afros and things all like that. And basically, long story short, is that it was commentated by a person who was of like who was Black, that was living in Tokyo for a long time, and she said she came across a group of Japanese people that, you know, they're like fourth, fifth generations removed from, I guess like I guess the origins of like hip hop, I guess, so to speak, that they think that they kind of like created this. And I bring it back to like medicine and coaching, and it's like, you know, the people who created these like techniques or coaching styles, some of them are obviously like still alive, but others may not be. But you know, the it can get diluted over generation to generation, and you know, we may just be at the point so far where you learn the test and you're like, well, I basically do it all the time. I created this stuff. I know exactly what I'm looking for, without having an acknowledgement of like the past, or because you get so like, you know, isolated in what you're able to see and surround yourself with. So I mean, I see that pretty often too in what you were describing. Like I'll ask someone like, oh, where'd you learn that? And they're like, from my preceptor here. And where'd your preceptor learn that? Well, from their preceptor. And it's just like, the closer you are to the source, you know, obviously you can figure out the nuances there. Like what's to like people give.
No,
Oh,
I
sorry,
think
go
you
ahead.
just nailed it on the head, dude. And I think, you know, I think this is probably where Phil's probably gonna get even more frustrated in August when he goes to PT school, is because physical therapy is probably worse than athletic training in what we call ecclesiastic succession, right? And that is where there's one all-powerful being who says, this is the way you do it. I am Dr. McMurray, and this is the way we do the McMurray test, because I'm naming it after myself because I have an ego bigger than this world, right? And then people start doing it a particular way, and then as generations go on, it gets watered down. And then someone else comes up with the Thessaly test, right? Well, that's Dr. Thessaly. So what ends up happening is it becomes this guru-based profession, and physical therapy has long been a guru-based profession. And so you know, in sports and orthopedic physical therapy, George Davies, hands down, is like that guru. But he's kind of debunked that a little bit by publishing, testing, researching, and doing all those other things that a lot of us don't, right? In clinical practice, we just kind of say, I learned this from Richard. Oh, I learned this from Rob. Oh, I learned this from so-and-so. And it becomes the way we mold our own little thing, right? And so we say that we learned this from our mentor who's a guru, and then we take that on, and that person becomes a guru, and the generations just kind of keep growing the legend, right? And I think that's long been a criticism of physical therapy, and where they just kind of take the word of someone and just pass it on. I think it's Mulligan has long said, you know, I create miracles in the clinic every day. who is he? You know, does he think he's God? Right. So, I mean, I think that's one of those things that you have to start questioning is, who is he to say he creates miracles where other people are not? Right. And I think that comes back to the scientific method of what are we testing? Like, what's the hypothesis? What are we using to test, and what's our reliability, and validity of this? And I think that's where physical therapy is long lagged in that, like, tremendously. So, and then again, I talk about this all the time. I had dinner with one of the higher ups at the APTA a few years ago at a meeting, and his number one concern with the profession was practice variance, that everyone does things differently, and that they can't somehow come down to a consensus of how people should practice. So then they come up with clinical practice guidelines, right? How many PTs can recite the clinical practice guidelines for shoulders and knees, right? So I'm just telling you right now that that's the problem. That's the reality, an unfortunate reality. So I think it's really good that Phil brings this up, because he's going to go from a profession like athletic training to a schooling of physical therapy, hoping for this moment where the gong rings and it's like, oh, and the light shines through the clouds and all this other stuff. But dude, it's actually going to be more frustrating. And I think that's kind of one of those things that I think you did a fabulous job of talking about, that the generations, it gets watered down from generation to generation. I think it's that whole thing of the rumor mill, right? So the first person starts passing the rumor, and by the time it gets to the fourth person, it's a totally different story. So I think the same thing happens in medicine, and so I think we have to be aware of that. So that was a great analysis. That's why I wanted to kind of
that was a really good analogy. I would agree. Yeah, and I think just like not only the clinical practice guidelines in the physical therapy realm, but even like some of the position statements too. I think it's just like it's good recommendations, but it's like, how are we gonna, like, we know the general idea of it, but but every setting has its different variances depending on what resources are available. So how are we gonna uphold that position statement if we don't have a lot of resources available, right? So I think but at the same time, I feel like these guidelines are good. Like the guidelines and the position statements are good as a reference, and that's what we should be striving for, because it's all based on the literature that's already been appraised, and what do we think it's best practice, just depending on how we evaluate the evidence, right? But yeah, man, we talked a lot about a lot of different things about this. I did not, honestly, before this, I did not expect talking about MRIs and ultrasounds, and then all of a sudden Aaron comes in with generational talk, and now I'm like, am I gonna be watering down something that everyone here taught me? It's like, oh man, this is gonna be great. But
that's cool.
But yeah, I think but yeah, this was definitely a great conversation. I mean, does anyone else have any thoughts about what we talked about, or anything you guys that's kind of like in the back of your mind, you guys wanted to say something? Oh, yeah, we got everything out of our systems for now. Good. Okay. I do want to make an announcement. So we did find out a way to get continuing education units for these Think and Drink sessions. I don't know if the DOC is gonna. What was that, Scott?
That's awesome.
Yeah. So I don't know if they're gonna audit us on what we're drinking, but they're definitely gonna audit us on the course objectives and what we're doing. So starting in June, we're just going to kind of hash out a couple finer details, making sure that it's legit. And I definitely put this as private because I don't want people assuming, oh man, you guys are bastardizing the physical therapy and athletic training profession with alcohol. And I don't know, some people are going to bring over like I have no idea. I'm enjoying this Kentucky Mule right now and this conversation, but yeah, we're gonna make this a Con Ed. We're gonna offer Con Ed units of one Category A unit, which would be definitely worth it. And yeah, after each session, we'll do a quick survey, and it's just a good reflection on what we brought up, and yeah. So yeah, we will have these every 2 weeks, every other Thursday. And feel free to let me know if there's anyone you know who are interested in joining. And I'll give you guys more details about the CEUs. And I promise next time there will be no technical difficulties with the Zoom. But yeah,
don't worry about that, Phil.
I'll definitely hash that out for the next one. But yeah, thank you guys for joining in. And this was a great talk. I felt like I learned a lot from everyone.
Cool. Hey, Phil, before we take off, though, I just want to give a shout out to Phil for this because, I mean, this is really his brainchild, right? So, I mean, just to think of getting people together from, you know, from different high schools, you know, from Los Gatos to Midi. Now we're going outside to, you know, where Aaron, Audrey, all you guys are kind of looking at. So, you know, I think it originated with, you know, our clinic outreach, you know, therapy and as well as athletic trainers, but now it's kind of just expanding even bigger. The fact that he can even get CEUs for this is kind of even above and beyond. And so, so I just think he's done a fabulous job. I think you guys keep, you know, within your circles, expand it. And I think this can be something that continues to grow, especially with a shelter in place. Right. So, you know, and so, I'm going to throw this out there again. So I don't know, Phil, Paca, you guys were on my group text tonight. I sent out Mike Reinold, who's, you know, PTAT out in Boston, and well-known guy. He just did a podcast on reopening his physical therapy clinic and the procedures that you need to do to be safe after COVID-19. And, you know, we did that. We really didn't close very much during the time of this whole pandemic. And it's largely due to Phil, Paca, another one of our aides, Thomas, and things like that, because the ATs, dude, I'll be honest with you, we went straight to the AT kits and started coming up with PPEs and ways to kind of keep people safe and things like that. And the thinking of the ATs is just, you know, it's crisis management. I mean, that's what you guys do on the sidelines. So, you know, I was like, this is exactly why, you know, our clinic is going to be in a very different position than a lot of other physical therapy clinics. So, again, shout out to Phil and Paca and, you know, everyone, you know, Justin, you know, for being affiliated with us, because this is the reality. This is why I love athletic training. You know, I mean, you guys guys do so much more dirty work that people don't recognize, and really kind of, you know, push it to a different level. And so if there's any way that we can, you know, continue to bridge the gap between physical therapy, athletic training, and make it better for our student athletes, that's what we're all for. So, so I like I said, I appreciate you guys, but I mean, Phil's done a fabulous job, and, you know, kudos to him. So thank you very much, guys.
Very good.
I can't take all the credit, because without you guys, I would just be talking to myself, and that'd be really boring. But you guys are definitely making this. You guys are definitely making this a reality, and I mean, I hope everyone here just hopes that this can keep going on, especially with the shelter in place. Yeah. Cool.
Thanks, Phil.
Oh, sorry, Scott. I thought you wanted to say something, but
no, thank you for the opportunity. I appreciate it. The one thing I get out of this is I hate Zoom. I hate Zoom meetings. I'd rather see you guys in person. But just the fact that I get the opportunity to see you guys more often too is a plus too. So I appreciate that. Maybe some days we'll get back to rookies.
Yeah, yes, definitely.
Hang out there, but yeah, maybe later on down the road. But this will do for now.
Yes, we'll have to make do for sure. All right, well, we'll see you in 2 weeks. I believe that will be June 4th. So I'll send out all the details. If you guys have any journal articles you guys want to bring up, shoot me an email. I usually send out the next topic on the following Monday. So that way everyone has a chance to read and come up with all these rants that they want to just unleash all their stress. So yeah, shoot me an email about a journal article, and I'll send out the email on Monday, and we'll get it all rolling.
We can try to find something about imaging and comparing them or something. That would be cool.
Okay, yeah. That'd be a good topic.
I'll look, but everyone.
Yeah, I did actually just find one.
Nice.
It was on Journal of Risk.
You just come up with a new topic for next session.
Yeah, so it's a, let's see, I got it right here. Oh, shit. No, sorry.
All right.
I lost it. My bad.
Well, yeah, send it my way, and then we'll get it all taken care of.
Okay, perfect.
Bryce Blatz might be a good resource too. He might have some articles that he can refer us to.
Okay, sweet. Yeah, we'll reach out to him. All right, awesome.
All right.
Thanks for joining in. You guys have a great night. Stay safe, stay well, and think and drink.
There you go.
Cheers, guys. Thanks.
Bye.
Cheers.
Bye. It's good seeing everyone.
Hey,
Stay safe.
good seeing you.
Nice to meet you guys.